Hello and welcome back to Counter 10. In today's episode, we'll look at the functional anatomy of the respiratory system. Now, this topic has 6 learning objectives, and the first 2 objectives that we'll look at will be the upper and lower airway anatomy. Now, unfortunately, anatomy is one of those topics that either people love it or they hate it, but what I'll try to do is try to link as much clinical context to anatomy as possible so that it sticks a lot more. Unfortunately, when it comes to airway anatomy, it's a non-negotiable and you must know it well. Afterwards, we'll look at the reflexes within the respiratory system and how these are affected by anaesthetic drugs. And then finally, the 2 learning objectives that kind of get lumped in with this topic, we'll look at humidity and the non-respiratory functions of the lung. As always, we'll end with looking at some of the past SAQs. And certainly, when it comes to anatomy, there are a lot more SAQs from the ICU exam that we'll look as an example as well. Now, like all respiratory topics, it's jam-packed. We'll try to make this as interesting as possible, so let's dive straight in.
1, 2, 3, 4.
The first learning objective is describe the anatomy of the upper airway, larynx, and trachea, including its innervation and endoscopic appearance. Now, to me, when I hear the term upper airway, this refers to everything above the larynx. Before we get into describing the anatomy, what you need to have in your head for an SAQ or a Viva is just a basic way to structure your answer when it comes to an anatomical question. The way you can do that is initially talk about the landmarks around that anatomical structure, the basic structural anatomy of that structure. You can then talk about and go into its relationships, the blood supply, the lymphatic supply, and then the sensory and motor innervation. Now, to begin with, we'll talk about the mouth and the nose. Now, obviously, you don't have to know a lot about these structures, but you just need to know the key points. So the mouth's basic structural anatomy can be divided into 2 areas. We have an area called the vestibule, which is the space between the teeth and the lips and the cheek. Now, if you imagine inserting your toothbrush to brush your teeth, when you're putting it at the front, that space where you're putting your toothbrush is the vestibule. Now, anything behind the teeth is known as your mouth cavity, and that's your second area. The other important thing about the mouth is its palate. So you have a hard palate, which is made up of the palatine process of the maxilla, and then you have the soft palate that just comes off the back of that, and that's where your uvula sit. Now, clinically, when you can't see the uvula and you can't see the soft palate, that's when we say we have a Mallampati score of 4. The other important thing with the mouth is its innervation. So it has innervation from multiple nerves, and these include branches of the vagus nerve, branches of the trigeminal nerve, and the glossopharyngeal nerve. The tongue is also very unique in that its sensation is divided into 2 areas. So we have the anterior 2/3 of the tongue, which gets its sensory sensation from the chordae tympani. Now, the chordae tympani is that special nerve that gets its branch off the facial nerve, which wraps around the ear to give off that chordae tympani branch. The posterior 1/3 of the tongue's sensory innervation is done by the glossopharyngeal nerve. The role of the mouth in general is to help with respiration, mastication, salivation, so that'll be important with both digestion and immunity, speech, and then sensory function with taste. Moving on to the nose, we can then divide the nose into 2 areas when we're describing it. We can divide the nose into the external nose and then the nasal cavity itself. So the external nose is just the cartilaginous structure which is then supported by the nasal bone. And then the nasal cavity is then divided also, like the mouth, into separate areas. So we have a vestibule of a nasal cavity as well, and this is just the initial part as you're going into the nasal cavity, so like the first 1 centimeter. Then we have the respiratory area of the nasal cavity. So this is where your concha lives. So you have an inferior, middle, and superior concha. And in between them, we'll have the spaces where the gas flows. And then we have an olfactory area, which is near the superior concha, which is obviously going to be important with smell. The key thing to know with the nose is that its blood supply is really unique. And it's unique because there's a lot of blood supply to the nose. So there's a lot of collateral arteries that come together to supply the nose. And where these come together forms a little area in the lower anterior septum called Little's area. And this area and the branches coming together make a plexus called the Kisselbach's plexus. And that's why the nose is a highly vascular area which is likely to bleed and cause epistaxis. So when we're inserting a nasopharyngeal airway or we're doing anything or instrumenting through the nose, that's why it's a high likelihood area of bleeding. The other important thing to know with the nose is its innervation, because typically we're trying to block the nose's innervation when we're trying to do a awake fiber optic or a nasal intubation or insert a nasopharyngeal airway, and we could typically use cofenlicaine spray to do that. So the nose innervation or sensory innervation is done by the trigeminal nerve, and importantly it's done by the ophthalmic division and the maxillary division of that trigeminal nerve. So that's what we're typically trying to block in terms of its sensory innervation. The last thing that's important to know about the nose is its function. So the nose is important in both humidification and warming of inspired air. It's important in trying to maintain and absorb heat. It's important in sensation. We've talked about smelling as well as sensing air temperature. It's important in speech through nasalization. And then it's important in giving us protective reflexes such as sneezing. Now, clinically, what's important to note, when we're trying to do a nasal intubation, we know we have our inferior middle and superior concha. The reason we insert the nasal tube down the inferior concha or beneath the inferior concha is just because that's where the biggest passage lies. So that's why we typically go down the right nair, because apparently the right nair is thought to be slightly bigger than the left nair, and we're going nice and low and straight back down that inferior concha or beneath that inferior concha to give us the biggest area to insert our ETT. So now moving on to a different structure that we have to know really well, and that is the pharynx. So to describe the pharynx, we can define it as a wide muscular tube that forms the common upper pathway of the respiratory and the alimentary tracts. We can then divide the pharynx into three areas. We have the nasopharynx, the oropharynx, and the laryngopharynx, which is sometimes known as the hypopharynx. Each of these areas has a boundary, so the nasopharynx essentially lies beneath the nasal cavity and above the soft palate, and it communicates with the oropharynx via the pharyngeal isthmus. The important thing about the nasopharynx is this is where the adenoids lie. So when we're doing an ENT case, we can recognize that because the ENT surgeons will use a mirror to look back up into the nasopharynx to try to find the adenoids. The oropharynx lies behind the mouth opening, and it kind of extends from where the soft palate kind of ends down to the tip of the epiglottis. And this is where our tonsils sit. So our adenoids are in the nasopharynx and our tonsils are in our oropharynx. Now the last structure is the laryngopharynx, or sometimes known as the hypopharynx. And you can broadly say that the boundaries of this is from the tip of the epiglottis to the lower border of the cricoid. And the cricoid lower border is usually at the C6, C7 level, but note that in neonates, the cricoid will be around about the C3 level, so much higher up. The important thing to recognize is that the laryngopharynx or the hypopharynx is separate to the larynx. The larynx bulges into the space of the laryngopharynx, and where it bulges in is where it leaves a little recess, and that recess creates that piriform fossa. Why is that fossa important? That's the fossa where typically food will get stuck when you're trying to eat stuff, and that's where the ENT surgeons will typically go and retrieve food from. The other clinical aspect that's important to know with the pharynx is that, again, obviously it's an area that we're trying to block when we're trying to do an awake fiber optic. So when we're trying to block the sensation, when it comes to the sensory sensation of the nasopharynx, we're trying to block the maxillary nerve coming off your trigeminal nerve. So the maxillary branch is coming off your trigeminal nerve. In the oropharynx, we're trying to block the glossopharyngeal nerve, and this will help to block the gag reflex. And then in your laryngopharynx, we're trying to block the branches coming off the vagus nerve. So this will be the recurrent laryngeal nerve and then the superior laryngeal nerve as well. And we'll talk about this a bit more when we get into the larynx. The final thing about the pharynx that's important to know as a whole is its function. So it's important in swallowing, separating the digestive tract and the respiratory tract. It's important in phonation, and it's important in immune function as well. Now we can move on and talk about the larynx. And the basic structural anatomy of the larynx is that it's considered to be part of the respiratory tract. It divides the upper airway anatomy from the lower airway anatomy, and its relationships can be described as being superiorly bound to the hyoid bone. Inferiorly, it becomes continuous with the trachea at the level of C6, C7, so the inferior border of the cricoid. Anteriorly, we have the skin and the thyroid cartilage, and posteriorly, it projects into that laryngopharynx. And the other unique thing about the larynx is that it has a laryngeal inlet. So this points backwards and upwards, and it's bounded anteriorly by the upper edge of the epiglottis. Now, just for completion's sake, we can describe the larynx's blood supply, venous drainage, lymphatic system, as well as the innervation. Although you're unlikely to be asked about blood supply, you can say that the blood supply to the larynx, the upper half and the lower half are divided. So the upper half is supplied by the superior laryngeal branch of the superior thyroid artery, while the lower half is supplied by the inferior laryngeal branch of the inferior thyroid artery. And these are then reversed or mirrored when we're talking about the venous drainage. The lymphatic drainage of the larynx, it goes into the deep cervical nodes, and then the innervation is unique. So off the vagus nerve, what we have initially is the superior laryngeal nerve. The superior laryngeal nerve has an internal branch and an external branch. The internal branch will supply the sensation to anything above the vocal cords, and the external branch will supply its innervation to the cricothyroid muscle, which is one of the main intrinsic muscles of the larynx. Then when we go back to the vagus nerve, we also have a recurrent laryngeal nerve. The recurrent laryngeal nerve does two things. It supplies the sensation to everything below the vocal cords, and it also supplies the rest of the intrinsic laryngeal muscles. So the only one that isn't supplied by that in terms of its motor function is the cricothyroid muscle. The functions of the larynx kind of mirror the functions of the pharynx. So the larynx is important in respiration, swallowing, phonation, and it's also important in the cough reflex, which is going to be part of your immune system. So taking a more detailed look of the larynx because of its importance, we can divide the larynx into three important structural key points. The larynx has cartilages, it has ligaments, and it has muscles. So the cartilages that are part of the larynx, there are 9 in total. 3 of them are paired and 3 of them are unpaired. So the 3 paired ones are your arytenoid cartilage, your corniculate cartilage, and your cuneiform cartilage. So an endoscopic appearance when you're doing a grade 1 view and you're looking at the larynx, these are kind of the posterior parts of the larynx when you're looking at the vocal inlet. So it's coming from the posterior to the anterior aspect. The 3 unpaired cartilages are your thyroid cartilage, your cricoid cartilage, and your epiglottis. Then we have ligaments. So the ligaments of the larynx can be divided into structural ligaments, which are going to be obviously important in support, and functional ligaments. The most important functional ligament is going to be your vocal ligament. And the vocal ligament is your true vocal cord. So this comes off your cricovocal membrane. You also have a false vocal cords in your larynx, and this comes off your quadrilangular membrane to make your vestibular ligament. Why that's important is because this area here, when you're having an anaphylactic reaction, can swell and lead to you having an airway obstruction. It's typically the area where the ENT guys, when they're doing their suspended laryngoscopy, will look at and say, that's my left and right ventricle. So this is the space between my true vocal cord and my false vocal cord. When it comes to the structural ligaments of the larynx, these are kind of really simple to remember because they're in their name. They kind of describe where they're attaching to and where they're inserting to. So these include your thyrohyoid ligament, your cricothyroid ligament, your cricotracheal ligament, your thyroepiglottic ligament, and your quadrilangular membrane. Now, for example, we all know our cricothyroid ligament because this is where we'd go for our front of neck access. The last thing with the larynx is its muscles. So we've already said we have intrinsic muscles, and because we have intrinsic muscles, we must also have extrinsic muscles. The important thing to know is what the intrinsic muscles do. There are 6 basic intrinsic muscles, and these involve the posterior cricoarenoid and the lateral cricoarenoid. The important thing with these 2 muscles is that they do the opposite to each other. So the posterior cricoarenoid abducts your vocal cords. So this means it opens up your glottis, while your lateral does the opposite and it adducts your vocal cords, and this means it closes your vocal cords. Then you have the interarytenoid muscle, which helps to close the posterior part of your vocal cords. We then have our thyroarytenoid muscle, which helps to relax our vocal cords. Our vocalis muscle, which sounds like a muscle that a singer would have, so it adjusts the tension of our vocal cords. And then we have our cricothyroid muscle, which is the only muscle that's done by not the recurrent laryngeal nerve, but done by the superior laryngeal nerve and the external branch of that nerve. And the function of that muscle is that it's also a chord tensor, and it typically raises the pitch of your voice. So when you have that ablated or not working, you might get a hoarse voice. And that hoarse voice or the change in voice tone is a sign that we look for when we're trying to do an awake fiber optic. Remember, when we're trying to do an awake fiber optic, there are two goals: the loss of the gag reflex and a change of our voice tone to indicate that we have anesthetized around the vocal cords well. And clinically, we can achieve blocking these areas by either blocking them visually as we're going down with our camera and spraying the vocal cords. We could block them using different types of external blocks. So we could do a transtracheal block, or we could do a superior laryngeal nerve block, which is using the anatomical landmarks from the hyoid bone and the thyroid cartilage. But when we're trying to do an awake fiber optic, there are certain goals that we're trying to reach and certain nerves that we're trying to block. So initially in the nasopharynx, we're trying to block the trigeminal nerve. In the oropharynx, we're trying to block the glossopharyngeal nerve. And in the larynx, we're trying to block the branches of the vagus nerve. And this completes our first section about upper airway anatomy. Moving on to our next learning objectives, we have outlining the anatomy of the lower airway. Now, when it comes to our lower airways, we've already delineated this from the upper airways by saying it's anything below the level of the larynx. And we said that the larynx ends at the inferior border of our cricoid cartilage. So in an adult, this would be around about C6, C7, where the trachea starts. So the lower airways involves the tracheobronchial tree. And West describes this tree in the nicest way possible by using generations to describe the tree as per the Weibels Zones. What that means is that essentially when you look at the trachea, it divides into two each time. So the trachea divides into the left and right main bronchus, which then each divide into a lobar branch, which then each divide into a segmental branch, which then continue to divide and divide and divide. And each division is then known as this Weibels zone. Overall, Weibel describes that there's 23 generations in total, and then he further classifies this into a conducting zone and a respiratory zone. What that means is that it's a division in the respiratory tree where there's gas exchange occurring and there's no gas exchange occurring. So the conducting zone is the first 16 divisions of our tracheobronchial tree, and these are areas where there is no gas exchange occurring. So they make our anatomical dead space. Dead space is space where there is ventilation but no perfusion. So this involves our trachea, our left and right main bronchus, our lobar bronchi, our segmental bronchi, our bronchioles, all the way down to our terminal bronchioles. And the reason why there's no gas exchange occurring is because there's no alveoli in this area. However, what this area does have is that it has goblet cells, which help to produce mucus. It has cilia, which help to drive up that mucus and is then part of our mucociliary apparatus. And that conducting airway has high flow of oxygen or high gas flow, which produces turbulent air, which, as we know from our last episode, helps to create eddy currents, which try to expel stuff from our airways to keep them nice and clean. Now, the total volume of our conducting zone is not that much. In a healthy adult, it's roughly around about 2 to 3 mils per kilo, approximately estimated at around about 150 mils, or it's quoted usually at 150 mils in a healthy 70 kilo adult. Now, in contrast, our respiratory zone is the area where gas exchange is occurring. So by definition, this is areas where we would have alveoli present. So it starts from the respiratory bronchioles, going down to the alveolar ducts, SAQs, and then the alveoli themselves. And the area in the respiratory zone comparatively is around about 50 to 100 meters squared. And this is important because we want that large area to maximize the area for diffusion to occur to maximize gas exchange. In the respiratory zone, we can look at the anatomy of an alveoli further. So the alveoli is the basic unit of ventilation in the lung. There is approximately 200 to 600 million alveoli in the lung itself, and the diameter of an alveoli varies from approximately 0.2 to 0.3 millimeters. The other important thing with an alveoli is the interface between the alveoli and the blood. So this is referred to as the blood-gas barrier. And you want this barrier to be as thin as possible so that diffusion has to go the smallest distance, or gas exchange has to go the smallest distance possible so that it can be as efficient as possible. So as gas traverses this blood-gas barrier, it must pass through certain layers. The initial layer it must pass through is the alveolar epithelium, then going through the basement membrane of the alveolar, going into the interstitium, going past the basement membrane of the capillary endothelium, and then going through the capillary endothelium itself. Now this blood-gas barrier is super small and super thin, and it's said to be approximately 0.3 micrometers wide. Being so small makes it a very efficient area for gas exchange to occur. Now looking more at the alveolar cells itself, we can say that there's 3 types of alveolar cells, and they can be divided into type 1 pneumocytes, type 2 pneumocytes, and alveolar macrophages. So type 1 pneumocytes are by far and away the most predominant, and they make your alveolar surface area. So these are 90% of the cells are type 1 pneumocytes, and they're involved in gas exchange. The unique thing about these type 1 cells is they cannot replicate. However, we have our type 2 pneumocytes, which are our specialized secretory cells, and these form surfactant that we've talked about before, and they have the unique ability to be able to divide to be made into type 1 cells. But because they're only 10% of the total amount of alveolar cells, you can imagine that even if they start dividing, it wouldn't be enough to compensate for the damage if you had gross damage of our type 1 cells. Then we also have alveolar macrophages, and the reason we have macrophages here in the respiratory zone is because unlike in the conducting zone where we can have cilia and the mucociliary apparatus, we don't have the cilia present in our respiratory zone. And this is because if we have mucus and cilia present here, we would increase the resistance dramatically in this area and make it very inefficient for gas exchange to occur. So we need another way to form a defense mechanism, and that's with alveolar macrophages. Moving on, the next learning objective is describe the physiology of the airway, including airway reflexes, and we'll combine this with the learning objective describe the effects of anaesthetic agents and other drugs on airway reflexes. Now, before we go looking into specific reflexes, we just have to remind ourselves, what does a reflex arc involve? Remember, it must involve an effector, so something sending up a signal to a controller, and then that controller giving an effector signal. So it has an effector, a controller, and an effector. And so there are a lot of airway reflexes that we know of. We have sneezing, coughing, gagging, and coughing is usually the one that's always asked in a Viva setting or in a SAQ setting. That's the one that we'll focus on. So a cough reflex is a protective reflex which is used to remove foreign objects from the airway. It can be elicited voluntarily, but only truly done involuntarily. And what I mean by that is you can do a cough voluntarily, but it doesn't produce the same force as an involuntary cough. So a true cough can only be done involuntarily. So like we've described, you need a stimuli or an effector to start this arc, and there can be multiple stimuli that generate or start this cough reflex. These can be chemical stimuli such as like acid and pathogens within the airway. They can be mechanical stimuli such as aspiration of liquids or solids, or they can be biological stimuli. The role of the cough is protection of the airways, but there's other roles of the cough as well. It can be a pathological consequence when there's damage to the mucosa, or it can also be a diagnostic way to see whether there's any kind of medullary function still active. So the efferent pathway starts with sensors that are located throughout our airway and our upper airway. So they're located the pharynx and then the trachea being the high point of localization of receptors being the carina. So if you've ever seen a spontaneous breathing technique where they go down for a bronchoscopy and they spray the carina with some local anesthetic, the patient always coughs because it's a really highly dense area or a highly dense sensor to elicit the cough reflex. These signals are being carried by our glossopharyngeal and our vagus nerve, and they're going into our controller via our nucleus tractus solitaris, and our controller is located in the medulla. Now, there is no defined specific area in the medulla, which is the area for our cough. So we have an indeterminate area, which is likely in the medulla, which we say is the cough center. So in your answer in the SAQ, you can say there's no identifiable cough center, but likely located in the medulla. The effector arc of our cough is going to be signals down our nucleus ambiguus and our dorsal motor nucleus to our vagus, and it's going to involve a coordinated response between our diaphragm, our abdominal muscles, our intrinsic and intrinsic laryngeal muscles, and our pharyngeal muscles as well. And these are going to be coordinated by our vagus nerve and our glossopharyngeal nerve. So when you're describing this effector response, we can say that the process of a cough has 3 stages. The first stage is the inspiratory stage, or the inspiratory phase, which is prior to the cough beginning. You take a deep inspiration with an open glottis. Then we move on to our second stage, which is called the compressive stage or our compressive phase. This is where we close the glottis and start to do a forced expiration against the closed glottis. And here, the pressure inside of our thorax can reach like 100 millimeters of mercury. The reason we're generating this force is to then get into our third phase, which is called our expulsive phase, which is where our glottis opens and that rapid pressure expels that expiratory flow, and that flow generates turbulent flow. The reason we want to generate turbulent flow is because when we spoke about it last episode, we said that turbulent flow generates things like eddy currents, and that eddy currents will help to cause chaotic flow, which will grip things from the side walls of our respiratory tract or our side walls of our mucosa and expel things upwards. We don't want laminar flow because remember, laminar flow has that velocity profile. And that velocity profile naturally means that on the side walls, the flow is almost stationary. Where we have all the stuff stuck that's causing the sensation to cough is usually generally on the side walls. So we want to expel that up along with the mucus, and that's why we want to generate turbulent flow. And here, the flow can be so fast that it can be said to be up to around about 80 kilometers an hour in terms of its speed. So that's the cough reflex in a nutshell. The other reflex that I want to briefly touch on is the laryngospasm reflex. So the laryngospasm reflex is essentially described as a laryngeal closure reflex which occurs rapidly to protect the airways. So the typical laryngospasm is a sustained closure of our vocal cords, resulting in either a partial or complete loss of a patient's airway. And so remember, the sensation above the vocal cords is done by the internal branch of our superior laryngeal nerve. So this is going to make our afferent pathway. Our efferent pathway are going to be the muscles or the intrinsic muscles that close the vocal cords. And we said the ones that close the vocal cords are our lateral cricoarenoid and our interarytenoid muscles. So these close our vocal cords shut. And so the way you treat this or stop this reflex occurring is by removing the stimulus. So you might suction out the stimulus if it's like blood or mucus that's stuck in there that's causing that reflex. You give the patient 100% oxygen, give them some positive pressure, and you deepen their anesthetic. And if that doesn't work, you paralyze them to then ablate the muscles from causing that partial or complete obstruction. The final reflex that we'll briefly touch on is the gag reflex, or also known as the pharyngeal reflex. So the stimulus for this reflex will be any sensation to the base of the tongue, the tonsillar pillar, or the posterior pharyngeal walls. And remember here, the sensation is going to be carried by a glossopharyngeal nerve. And so this is the nerve that we're trying to block we're trying to do an awake fiber optic. The integrator is again going to be in the medulla, and our effector is going to be our vagus nerve. So now that we've described the majority of reflexes, or the important reflexes, we can then go on and talk about how we alter these reflexes with our anesthetic agents. And so this is an important part of our day-to-day job. You can block these reflexes by thinking about the reflex arc. So you can block them in terms of an afferent signal. So what we're trying to do when we're trying to do an awake fiber optic and use local anesthetics to block that afferent signal pathway. We can block it centrally by deepening anesthetics, so using agents like propofol to deepen the anesthetic, or we can block the effector signal by using drugs such as neuromuscular blocking agents to block the muscles that would be causing that reflex. So if you know the arc, you can then logically think how we're going to block this and what drugs we use in an anesthetic setting that are going to be able to aid with our blocking. Certain drugs are going to be able to do things better than other drugs. So typically when you read about thiopentone, you will read that thiopentone maintains laryngeal reflexes compared to propofol, which depresses laryngeal reflexes. And this is going to be beneficial. Say we're trying to put an LMA in, we'd use propofol instead of thiopentone. Ketamine is also one of those drugs that says that, airway patency will be maintained and our laryngeal reflexes will be maintained. In kids, we typically do a gas induction. So we want to choose volatiles that aren't going to elicit these specific reflexes. So we don't want to use volatiles such as desflurane, which is an airway irritant. We don't want to use volatiles such as sevoflurane and nitrous oxide to help put a patient to sleep or put a kid to sleep, which are not going to be airway irritants and elicit these reflexes. Because what we don't want to have is a kid go into laryngospasm. One of the interesting things that Nunn says about laryngospasm reflex is that it says that the reflex laryngospasm is still possible at depths of anesthesia that suppresses other airway protective reflexes. So what that means clinically is that even if a patient has an ablated cough reflex, they might still be able to go into laryngospasm. And certainly we know that the biggest way to prevent laryngospasm is to recognize the triggers. The trigger of laryngospasms can be assessing anesthetic related factors, so assessing the depth of anesthesia. The inductions, the emergence are the highest areas where laryngospasm can occur. Looking at patient factors, so knowing that it's higher likelihood in pediatric population, they have a history of asthma or a recent upper respiratory tract infection, and then looking at the surgical factors as well, so seeing if they're going to have a sudden amount of stimulation, such as what you would expect with someone having a perianal abscess and having the initial incision. So those are all the things we can do on a day-to-day basis to help prevent that reflex from occurring. So what we're trying to do there is block that initial afferent pathway, so the sensation pathway before it gets to the controller, so that it doesn't get activated. So that pretty much covers the airway reflexes part, and it moves us on to the weird part about this topic today, which is talking about humidity and the non-respiratory functions of the lung. So the learning objective for humidity is define humidity and outline the importance of humidification. Now, humidity can be defined as a term used to refer to the water content of a gas volume. There are two important ways to define humidity. We can talk about humidity as being either absolute or relative. And so if you think about the terms, absolute must mean the actual amount, which is typically the units being grams per meter cubed, and relative being a fraction or a percentage. So it's the absolute humidity, so the actual water vapor in that gas, divided by the absolute humidity saturated at that temperature. So saturated meaning that how much can it hold in total. And if we take these two numbers, we then get a percentage. So when we say we have 50% relative humidity, we're saying that we could increase that water content by another 50% in that given volume of gas to make it 100%. So if we have 75%, we could increase it by another 25% to make sure all of that gas was covered with water. Now, the unique thing to understand with relative humidity is that it's affected by temperature. In simple terms, if you make something hotter, you increase the amount of gas or the space that the gas can occupy. And so therefore, the amount of water that can be carried on that gas can be increased. So now we can increase the amount of water vapor that can be carried if something gets hotter, or if something gets colder, the opposite occurs. It's not changing the actual amount of water that's being held by that gas or the amount of water vapor present in that gas volume. So the absolute humidity is not being changed with a change in temperature, but the relative humidity is being changed. So the other term we've used here is saturated. So saturated, when we talk about it in terms of water vapor, means the point at which gas cannot hold any more water vapor. So saturated vapor pressure is essentially describing an equilibrium vapor pressure. So it's the pressure exerted by a vapor when it's in equilibrium with its liquid phase. So it's the rate of evaporation is equal to the rate of condensation. So in our body, what we say is that the saturated vapor pressure of water at a body temperature of 37 degrees is equal to 47 millimeters of mercury. And this is why we take it away from the atmospheric pressure when we're looking at it in the alveolar gas equation. So what does humidity and humidification have to do with the functional anatomy of the respiratory system? The goal of when we're breathing in cool gas is to make it warm and moist for our lower airways. And the reason we want to make it warm and moist is because it helps to keep our cilia nice and functioning well. So it keeps our mucociliary apparatus most optimal. It maintains that our mucus within our mucociliary apparatus is not going to be too viscous or too liquidy, so it's going to be working adequately. So it's important for immune function, and it's important to minimize heat loss within our body. When we're breathing in the cold air from outside, our goal is to warm up that air and give it as much moisture as possible. When we're breathing out the warm air from inside our body, our goal is to try to keep as much of that moisture within our body and keep as much of that heat in our body. So we want an efficient system where these things can be done without losing too much heat and without losing too much energy and water. So where these things get done is typically the nose and in the mouth. The nose has nose hairs and turbinates, which increase the propensity of that flow of air coming into our nose to become turbulent. And as it becomes turbulent, it starts to hit our mucosa in our nose. So it starts to warm up through our natural body. It starts to absorb the moisture that's there from the warm air being expired, and its humidity is being increased. So the absolute humidity is being increased and the relative humidity is being increased because that cool air's temperature is also being increased. By the time that air goes down past our nasal cavity, into our nasopharynx, going into our oropharynx, it's already reached a relative humidity of 85%. By the time it goes to the trachea and gets to the second generation of bronchi, it reaches 100% humidity. So it's very efficient breathing in through the nose to make the air humid as quickly as possible. The level at which the humidity reaches 100% through our respiratory tract is known as our isothermic saturation boundary point. And this point will change depending on how fast you're breathing. So if you're breathing really fast, it'll push down our respiratory tree. If you're breathing really slowly in through your nose, it'll go higher up. Now the mouth, as we breathe through our mouth, we don't have the ability to cause as much chaos in our gas flow. So we don't have the ability to exchange as much of that gas and make it warm and moist as possible. So as we breathe through our mouth, we only reach around about 60 to 70% humidity as we go into our oropharynx. This is typically why when you're sick and you have a blocked nose and you're breathing through your mouth, you start to have a dry throat because you're not being as efficient as if you were breathing through your nose at increasing the moisture and maintaining the heat within our breathing cycle. And inadequate humidification can lead to you losing around about 250 mils to 300 mils of water a day. Normally, when it's adequate, we only lose around about 150 mils, so we're not losing too much water. So if you have inadequate humidification, a patient can become dehydrated. The mucus can become viscous, and this can make your resistance in your airway increase, as well as decrease the function of your ciliary apparatus. You can start to have cytological damage of your tracheobronchial epithelium, and you can also get heat loss occurring. On the other hand, if you get too much humidification, so you're trying to keep too much of that moisture, keep too much of that heat, we can start to get pulmonary edema occurring. Our cilia don't like to be too hot either. We can start to get an increase in our AA gradient. We can change the compliance of our airways and our compliance of our lungs. We can become hypernatremic because now we're becoming hypervolemic, and we can start to decrease our hematocrit due to the dilutional as well. So ideally, a humidification device that we use will give us inspired gas at around about 32 to 36 degrees as it goes into the trachea. We'll be able to set the temperature on that humidification device. It'll be unaffected by any type of changes in gas flow. The device will be simple to set up, cheap, and it'll be safe and sterile. So the easiest one that we use is a HME filter, which is just known as a heat moist exchanger filter. There are other devices that you might see. So if you're giving someone high flow oxygen, you might have a bubble system, which is running that gas over some bubbling water, which is giving that gas moisture, increasing its humidity before it goes into the patient. Because remember, at that high flow, we have the high propensity to drying out our airways. So if we're using such high flows, we need to make sure we're giving moist air. So humidity is one of those topics that you don't think you need to know much about, but actually on a day-to-day basis, we use the core concepts quite frequently and every day when we attach an anaesthetic circuit to a patient. Now, our last learning objective is outline the non-ventilatory functions of the lung. Now, you would be not wrong of thinking that the lung doesn't have many functions if you thought, oh, well, the main function is gas exchange. But what you must always remember is that the lung is the only organ apart from the heart that receives all of the blood volume. So because of this, it makes it actually very suited to have other functions. And if you remember that, I have a simple mnemonic that helps to characterize all the non-ventilatory functions of the lungs. And this mnemonic is pre-admits, filter. So the P stands for phonation, which we don't need to discuss any further, but it's an easy one to forget, but it's also an easy one to remember and get a point out of. The R is a reservoir. So the lung as a whole has around about 10 to 15% of our blood volume stored. So when we're supine, we have around about 10 to 15%, but when we're actually standing up, that reservoir capacity goes down to 9%. The next thing in pre-admits is E. So the endocrine functions of the lungs have not been well defined, but it's thought to include release of inflammatory mediators like histamine and endothelins following an immunological activation. Then we have its role in acid-base, so its chief role in CO2 excretion for homeostasis, as well as CO2 excretion for compensation during a metabolic acidosis. Then we have its role in drugs, so it can be a route of administration of inhaled drugs, so things like your nebulized drugs like salbutamol or Atrovent, your other specific drugs like nitric oxide, which might help with pulmonary vasodilation. It's also a route of elimination of drugs, so you can exhale volatile anesthetic agents as well as inhale volatile anesthetic agents through there. The lung also has a small amount of cytochrome P450. So the P450 system is not just intrahepatic, it has extrahepatic sites as well. But the issue with the P450 system here in the lungs is that it has a small capacity and it's easily saturable. However, for some drugs, it's actually really important. So for propofol, we know that it has extrahepatic metabolisms, and it's thought to be around about 25% extracted from the pulmonary circulation itself. Fentanyl has 75% pulmonary extraction. Typically, they say that drugs that are basic with a pK of greater than 8 and are lipophilic tend to be taken up by the pulmonary circulation, whereas acidic drugs typically preferentially bind to plasma proteins. Then the next function of the lungs is M, being metabolic. So substances can either be converted, they can be inactivated, they can be stored, or they can be unaffected, and all these things are called biotransformation. The typical substances are either peptides, amines, or arachidonic acid derivatives. So in terms of peptides, we have our ACE, which helps to convert angiotensin 1 into angiotensin 2. It also helps to inactivate 80% of bradykinin. In terms of the amines, 30% of NORAD is removed in a single pass through the lungs, while adrenaline, on the other hand, is not affected at all. And the reason for this difference is because there's a lack of active transport mechanisms for adrenaline compared to noradrenaline that allows noradrenaline to be broken down within the lung circulation. Then we have arachidonic acid derivatives. So these are things like leukotrienes, which are usually made and stored within the lungs, and then these are released when we have an anaphylactic reaction. Then we move into the I, which is the immune function of the lung. So it's important in both innate immunity and adaptive immunity. So the innate immunity part is the mucociliary apparatus. It also has ability to remove inhaled particles depending on the size of that particle. So if it's a big particle, it might be impacted. If it's a moderate sized particle, so between 1 to 3 micrometers, it might be sedimentated. And if it's less than 1 micrometer, it might diffuse through. And then the adaptive immunity comes from the alveolar macrophages presenting to IgA and IgG. IgA is more abundant within the nasopharyngeal area, while IgG is more abundant as we go down the respiratory tract as we go further into the alveoli itself. Then the T is for thermoregulation, and we've already spoken about humidification and the role in helping to decrease heat loss, water loss, preventing crusting of the secretions, maintaining that mucociliary function, and to prevent infection as well. The S is for surfactant in terms of synthesis via the type 2 pneumocytes. And the last thing, filters, is just as the name says, the lung is a big filter which helps to filter out clots. That can be clots that are either blood, fat, or air. So this helps to prevent clots from going up into the brain. And other unique thing about the filtering function of the lungs is that it actually has the largest supply of heparin within the body. And that makes sense because you want to be able to break down any small clot that kind of forms within our lung system so that it doesn't go into the systemic circulation. So just to recap our mnemonic, which was pre-admits filter, the P was for phonation, the R was for reservoir, the E was for endocrine function, the A was for acid base, the D was for drugs, the M was for metabolic, the I was for immune, the T was for thermoregulation, S was for surfactant, and then the filter was just for the filter itself. So I didn't lie when I said that this topic would take us a little while to get through, but this brings us on to our SAQ section. So the first SAQ we'll look at is from 2013, where we were asked to draw the diagram of a larynx as it would be seen on a direct laryngoscopy and label the important anatomical structure. Now the examiner report here said to pass you need to draw and label the vallecula, the epiglottis, the laryngeal inlet, the cartilages, and the true vocal cords. Extra marks could be gained if you talked about the anatomical orientation, and then you said that this was a grade 1 Cormack-Lehane view. No marks were given if we talked about the nerves, the blood vessels, the muscles, or the function. So here, what you would draw is an anterior and a posterior aspect of looking into a vocal cord as you would see in a Cormack-Lehane direct view. The key structures you want to note is that if you're trying to draw this, what I usually did was draw the epiglottis first, because then you can draw the base of the tongue and the vallecula, and that's easy marks. And then you draw this kind of semicircle around the epiglottis, which is where you're going to have your arytenoids, your cuniculate, and your cuneiform ligaments. At the apex of those two structures, so the top and the bottom, is going to be your anterior and posterior commissure. And looking down in through your vocal cords, you're going to see your tracheal rings. You're going to have the false vocal cords and the true vocal cords. Remember, the gap in between makes your ventricles, which you don't need to label, but it's just a simple thing to recognize when you're actually doing stuff clinically. The true vocal cords is going to be your vocal ligament, which comes off your cricovocal membrane, and your false vocal cords is going to be your vestibular ligaments. So the important thing around those structures on the sides is going to be on the posterior aspect, you're going to have your esophagus, and you're going to have next to it your piriform fossa. The piriform fossa, remember, is that area where the larynx shoves into the laryngeal hypopharynx, and it creates that recess. And that recess is where stuff like food can get stuck, and that's where you typically go and retrieve a food bolus, or you get that kind of irritation that food is stuck in your throat. So you can see here how it's quite easy to draw a lot of these structures without actually knowing a lot about the specific anatomy if you just relate it back to the clinical context. Now, as a side note, just remember that when we talked about the larynx, we said that there's 3 important structures in the larynx. We said that there was cartilage, ligament, and muscles. There was 9 important cartilages, so 3 of them were paired and 3 of them were unpaired. In terms of ligaments, we divided them into structural and functional. And in terms of muscles, we had our intrinsic muscles and our extrinsic muscles. Our extrinsic muscles were the ones that help support and elevate our larynx. And those were muscles like our sterna, thyroid, our thyrohyoid, our mylohyoid, our stylohyoid. And the reason why I harbour on about this is because in 2015 from the ICU exam, they were actually asked to outline the anatomy of the larynx itself. And so in this question, you had to go and break down, as per the examiner report, the contents of the larynx, the relationship of the larynx, the cartilages, the ligaments, the muscles, the innervation, and the blood supply. So you'd have to go through all of those. And so what you would do is you just say the larynx is an anterior structure in the neck with a cylindrical shape, and its associations are with the thyroid gland, posteriorly with esophagus, and then superiorly with the hyoid bone, and then inferiorly with the cricoid cartilage. We know we've just talked about the 9 cartilages, the 6 ligaments, the muscles being the 6 intrinsic and the extrinsic muscles. Within the intrinsic muscles, the 2 that you must remember are the lateral cricoarenoid and the interarenoid muscles. And this is because these are the muscles that close the vocal cords. So they adduct the vocal cords shut. We talked about the innervation, so the sensory innervations by the internal branch of the superior laryngeal nerve, especially above the level of the vocal cords. The functions of the larynx is the one thing you can't forget, and that's easy marks. So the larynx is important in respiration, swallowing, coughing, phonation, and protection of the airways. The other anatomy question that could come up from the ICU exam that was asked in 2016 was outline the trachea, the left and right main bronchial tree in an adult. So here, it would be important to know that the tracheobronchial tree is divided into those 23 zones as per Weibel, and the trachea itself starts at the inferior border of the cricoid cartilage. It ends at the carina, which is at the level of T4, and it receives blood supply from the bronchial circulation. The trachea itself has D-shaped cartilage, and this is different to the cricoid, which is a cylindrical or a circumferential cartilage, and that's the reason why we apply cricoid pressure when we're helping to try to prevent aspiration in an RSI, which itself is a topical subject, but it's the reason why we apply cricoid pressure, not tracheal pressure. The mean diameter of a trachea is said to be around about 1.8 centimeters, but we're actually looking at, when we're looking at ETT sizing, the internal diameter of that ETT, not the actual external diameter of that ETT. Then we can go into the anatomy of the trachea going down into the bronchus. So the division occurs at the carina, as we've said. And the important things about the bronchus that they're trying to get at is that the left and the right main bronchi have different orientation. The left main bronchus is more horizontal, while the right main bronchus is more vertical. Also, other difference is that the right main bronchus is much more shorter. And clinically, this is actually quite important for us when we're trying to do a double lumen tube. So the right main bronchus is actually only 2 centimeters long, and the internal diameter of this bronchus is around about 10 to 16 millimeters. It breaks off into a right upper lobe and a bronchus intermedius lobe. The reason that's important is because if you're trying to put a bronchial blocker down the right main bronchus, you're going to actually not want to put it in too far because you might actually go past that first division up into the right upper lobe. Because it's only 2 centimeters long, you have to be very careful not to go past that. Comparatively, the left main bronchus is around about 4 to 5 centimeters long. The internal diameter is around about the same kind of size, 8 to 14 millimeters, and it breaks into a left upper lobe, a lingular, and a left lower lobe bronchus branch. So you got to ask yourself, when you get this question, why would an examiner be asking that? And the reason the examiner would be asking this question in an ANZCA setting is because it actually relates to our everyday practice, especially with a double lumen tube. So it's important to know the anatomy of the left and right main bronchus because we have the ability to do an endobronchial intubation every day. We also have the ability to block off the bronchi when we're trying to do a double lumen tube in certain types of surgeries. So clinically, it's actually quite important to know the anatomy and anatomical differences between the left and right main bronchus. Then the next SAQ from the ANZCA exam that we're going to look at is from 2013, which was describe the cough reflex. Now this had a really low pass rate of 12%, so I wouldn't be surprised if it gets asked again or if it gets asked in a Viva setting. The important things from the examiner report was that they really harbored on about knowing the reflex arc, particularly describing the efferent limb, and then knowing the muscles involved at these stages as well. And you can see how an examiner would justify this question to be asked again, because it's something that we're trying to ablate on a day-to-day basis whenever we're giving someone a general anaesthetic and manipulating their airways. So the way you would structure this answer is by briefly describing the cough reflex. So a quick statement to say that's an important airway protective mechanism, and the aim is to clear the secretions from the airways and protect from aspiration. We would describe that reflex arc in terms of the sensor, so an afferent limb, an integrator, and an effector. So the sensor is going to be irritant receptors within the walls of the pharynx, the trachea, and remember we said that the carina is a spot where there's lots of sensation, so it's a highly sensitive area. The pathway is going to be using those glossopharyngeal and vagus nerves going through the nucleus tractus solitaris up to the medulla where there's the controller, but there's no identifiable specific area. The effector is going to be signaled down the nucleus ambiguous and the dorsal motor nucleus of the vagus to muscles such as your diaphragm, your abdominal muscles, your intrinsic and extrinsic laryngeal muscles, and your pharyngeal muscles as well. And these are going to be coordinated using your glossopharyngeal nerve, your vagus nerve, and other nerves as well. The sequence of the cough is going to be very important to describe, and then that's going to involve the 3 stages. So an initial inspiration, compressive phase, and an expulsive phase. The key thing that examiners wanted you to understand is that the diaphragm is important in that initial inspiration phase to help increase the volume inside your lungs so that you can generate as much expressive expiratory flow during the expulsion phase. The key term you want to state again is that turbulent flow that's trying to be generated in that final stage where the glottis finally opens so that the foreign material can be picked up from the side walls of the mucus and expelled out with a cough. Remember, a cough can be done voluntarily, but a true cough that actually generates that high amount of flow and pressure can only be done involuntarily. If you had time and you got through this question quite fast, you can then try to put in some extra clinical context. So you could say clinically drugs that could affect my cough reflex would be drugs like opioids, especially codeine, which is a potent cough suppressant, propofol that decreases my cough reflex, volatiles like sevoflurane that help to decrease the laryngeal reflex. You could say you could try to avoid drugs like your desflurane that are airway irritants. You could try to avoid drugs that would maintain your airway reflexes, or your laryngeal reflexes, such as your ketamine and your thiopentone. And then finally, drugs that would be working on the effector part would be your neuromuscular blocking drugs, because then they'd be impeding your muscle function. Then we have 2 more SAQs left. Way back in 2008, we were asked what is humidity and how can it be measured. This question had a 50% pass rate. The examiner report stated that to pass, you needed to define humidity and at least 2 measurement techniques. You needed to define both relative and absolute humidity and the effect of temperature on both. You needed to talk about measurement techniques such as a hair hygrometer, a wet and dry bulb hygrometer, a Regnolds hygrometer, and then extra marks could be gained by talking about measuring absolute humidity using electrical transducers. Now, we didn't really discuss measurement techniques too much, but the way you could structure this answer is a quick definition of humidity being the amount of water vapor content in a gas mixture. And then you could say that absolute humidity is the total amount or the actual amount of mass of water vapor. And this is measured in grams per meter cubed. and the relative is a percentage of the actual or the absolute humidity divided by the absolute humidity that can be saturated at that temperature. We would say that temperature affects relative humidity, and that increasing temperature increases the ability to store more water vapor in the gas, and decreasing the temperature decreases the amount of water vapor that can be stored in gas. Relative humidity is the humidity that is usually dependent on temperature, while absolute humidity is independent of temperature unless we're 100% fully saturated. We could then go on and talk about measurement techniques. The most simplest measurement technique is describing a hair hygrometer. And essentially what it is that hair is held under a constant tension and it will absorb moisture. So as the moisture is absorbed, the hair gets longer, and using a scale and a pointer, you can essentially, as the tension and the moisture changes in the hair, you can then measure the relative humidity by seeing it where the pointer is pointing on a scale. Now it's good over 20 to 90% relative humidity, and the use of it is that it's easy to construct and it's very cheap. Then we have a dry and wet bulb hygrometer, and this is essentially two thermometers, one that's measuring the dry ambient temperature and the other one that's measuring a wet temperature through cooling from evaporation. The difference between the temperatures is then measured and then gives us an estimation of the relative humidity. Then finally we have a Regnolds hygrometer, or aka a dew point hygrometer. And you don't have to know too much about it apart from the fact that it's using a silver tube with a diethyl ether. And what it's doing is that the silver has a high thermal conductivity. So the temperature outside the box will equal what's inside the box. When air is put into the ether, causing the temperature to fall, evaporation of the ether occurs. And as evaporation occurs, you get to the dew point, which is essentially when water starts to spill over when it can't be held in gas anymore. If you keep measuring at different dew points, you can then start to make a scale, and then you can use the scale to get relative humidity. And it's through a complex kind of equation that this is done, but that's probably the most you need to know about this equation. It's very unlikely to be asked, because if you were to be asked in an exam setting, you would just be able to describe a hair hygrometer and a wet and dry bulb. And you just need to know the concept that a Reynolds hygrometer is using something called dew point, which is where the water vapor cannot be held in the gas anymore and it starts to spill over. And you see this every day when you go to your car in the morning when it's cold and you get the condensation of your car. Because the temperature at night has decreased so much, the amount that the water can be held in the atmosphere has decreased. That water has to spill over somewhere and it produces condensation on your car window or on your car surface. Final SAQs also from way back in 2005, where we were asked to describe the non-respiratory functions of the lung. This had a 50% pass rate back then, and the examiner report said that you could group answers as metabolic, vascular, immunological, thermoregulation, blood reservoir, phonation, acid base, and uptake functions of the lung. I don't think we need to harbour on about this question too much, as long as we remember, you have some kind of mnemonic to how to remember this. And my mnemonic again was pre-admits filter, but I've also seen on Propofol Dreams that there's been mnemonic firm tits. So it's really up to you whichever one you want to use, but pre-admits filter stands for phonation, reservoir, endocrine function, acid base, drugs, metabolism, immunological, thermoregulation, surfactant, and then filter itself. As long as you can get at least 5 or 6 points and you can quickly jot down those points, I think you'd pass this question. So this brings us to the end of our podcast today. So just as a quick recap, what we've discussed is the upper airway anatomy and the importance in the upper airway anatomy, especially in anatomy of things that we don't need to know too well, like the mouth and the nose, is just to know the key points. So the mouth, you would know that the sensation to the tongue, the hard and soft palate. The nose, you would know that there's a nasal cavity and the external nose, and the nose is a highly vascular area, and that's why it has an increased propensity to bleed, and that's why you get epistaxis more commonly from the nose. Then in terms of the pharynx, we can say that the pharynx is divided into 3 areas: the nasopharynx, the oropharynx, and laryngopharynx, and knowing where the boundary of each is. And then you would know the larynx really well, and you'd know the cartilages of the larynx, the ligaments of the larynx, and the muscles of the larynx. In terms of the lower anatomy, we were talking about knowing the Weibels zones and knowing there's a respiratory zone and a conducting zone, and then knowing the anatomy of the alveoli and the blood gas barrier that gas has to go through and how small it is to make diffusion occur as efficiently as it can. Talking about airway reflexes, you know the 3 stages of an airway reflex, being that you need a sensor, a controller, and an effector. And the way you can then cause anesthetic drugs to have an effect on these reflexes is by either blocking one of those arms or all of those arms on a reflex. The most important reflex that we commonly get asked on is the cough reflex, and known that it has 3 phases: the initial inspiration phase, the compressive phase, and the expulsive phase. And the importance of these 3 phases to generate turbulent flow so that material can be taken out of our respiratory system. Then we talked about humidity and how humidity can be divided into absolute and relative, and the role of humidification in making sure that the cilia is working well, that we're not losing heat and we're not losing moisture. Finally, we talked about the non-respiratory functions of the lung, and then we had a mnemonic for this being pre-admits filter. That completes a very long topic, and thank you all for listening, and we'll be back next week talking about gas transport in the blood.